This is our interprofessional collaboration project. There is a group of 4 of us. We have 2 PT students from the University of Jamestown, 1 University of Mary OT student, and an SLP student from Minnesota State University Moorhead. So what is physical therapy? Physical therapists are movement experts. We specialize in functional movements, patient education, pain management to help improve a patient's quality of life. As a profession, we treat all ages and all different sorts of musculoskeletal conditions, neurological conditions that patients can present with. As PTs, we work in a variety of settings, most commonly outpatient settings, acute care, inpatient rehab, home health, skilled nursing facilities. Some PTs can also be employed within the school systems. And in these settings, we work with a wide variety of patient populations, all the way from pediatrics to geriatrics to cardiopulmonary to cardiovascular, neurological, and there's also a bunch of others, different types of subspecialties and different certifications that you could also get in the physical therapy field. As far as duties for physical therapists, we diagnose and treat individuals that may have injuries, disabilities, and other health conditions. As PTs, we evaluate each patient on their first session, and then from there we will decide if they are appropriate for PT, or if they aren't, we need to make that proper referral to other healthcare professionals. So if they are appropriate for PT, we develop a treatment plan with the patient in order to help them achieve their goals. That treatment plan is based off of the biopsychosocial model. There are a wide variety of different types of interventions that are out there that many PTs use. Most of us kind of have a few core interventions that we like to use. So those are therapeutic exercise, patient education, manual therapy, and neuro re-education. So how to become a physical therapist? So first you need to obtain a bachelor's degree and apply to a doctor of physical therapy program. You then must graduate from an accredited DPT program, and then from there you take your boards, which are known as the National Physical Therapy Examination, or the NPTE. And then from there, depending on what state you are in, you have to apply for licensure and pay all their fees, and then you can practice. So most DPT programs are 3 years long. They include didactic coursework that includes biology, biomechanics, neuroscience, musculoskeletal, cardiovascular and pulmonary courses, communication courses, evidence-based practice, and also some PEDS courses. And then along with that didactic coursework, clinical learning experiences are also part of every physical therapy program. So as far as job outlook for physical therapists, the demand for PTs will continue to increase, and there are a couple reasons why that is happening. So people are living longer, and then especially now the baby boomers are reaching ages that will be in need of PT services. And so according to the Bureau of Labor Statistics, our profession is expected to grow 18% from 2019 to 2029.
Occupation is an activity or task that one does throughout their day that is meaningful to them and purposeful to their life. Basically, it's everything that occupies one's time. Occupational therapists are able to work with clients who have suffered from an injury, illness, or disability that has affected their ability to participate in these meaningful occupations. According to the AOTA, occupational therapy practitioners have a holistic perspective in which the focus is on adapting the environment and task to fit the person, and the person is an integral part of the therapy team. It is an evidence-based practice deeply rooted in science. How does one become an occupational therapist? First, one needs to earn a bachelor's degree and complete required prerequisite courses for their occupational therapy program. Next, they need to graduate from an accredited occupational therapy program. As of now, this can be either a master's or a doctorate. These programs are accredited by the Accreditation Council for Occupational Therapy Education, also known as ACOTE. Next, they need to complete their fieldwork requirements. After that, apply for and pass the National Certification Exam. This is put on by the National Board for Certification in Occupational Therapy. Finally, one needs to complete a license application for each state in which they wish to work. Each state may also have unique requirements, such as additional exams or additional background checks. According to the U.S. Bureau of Labor Statistics, employment of occupational therapists is projected to increase 16% from 2019 to 2029. This projected employment change is 22,700 jobs. Job opportunities should be good for occupational therapists in all settings, but particularly in acute care settings, rehabilitation, orthopedics, and anywhere where elderly are receiving treatment. This is partly due to the increasing age of our population.
What is speech-language pathology? Speech-language pathologists, or SLPs, work to prevent, assess, diagnose, and treat speech, language, social communication, cognitive communication, and swallowing disorders in children and adults. Speech disorders occur when a person has difficulty producing speech sounds correctly. Language disorders occur when a person has trouble understanding others, so receptive language, or sharing their thoughts, ideas, and feelings, so expressive language. Language disorders may be spoken or written and may involve the form, content, and use of language in functional and socially appropriate ways. Social communication disorders occur when a person has trouble with the social use of verbal and nonverbal communication. These disorders may include problems communicating for social purposes, talking in different ways to suit the listener and setting, and following rules for conversation and storytelling. Cognitive communication disorders include problems organizing thoughts, paying attention, remembering, planning, and/or problem solving. These disorders usually happen as a result of a stroke, traumatic brain injury, or dementia, although they can also be congenital, which is present from birth. Swallowing disorders, or dysphagia, are feeding and swallowing difficulties that may follow an illness, surgery, stroke, or injury. Additionally, speech-language pathologists may provide augmentative and alternative communication, or AAC systems, for individuals with severe expressive and/or language comprehension disorders. SLPs may also work with individuals who want to learn how to communicate more effectively, such as work on accent modification or other forms of communication enhancement. How to become a speech-language pathologist. Obtain a bachelor's degree and apply to a Master of Speech-Language Pathology program. Earn a graduate degree. Must graduate from an accredited SLP program. Successfully complete the required clinical experiences. Pass a national exam called the Praxis, and complete a clinical fellowship post-graduation, which is typically 9 months if you are working full-time, and apply for the Certificate of Clinical Competence in Speech-Language Pathology, known as CCC-SLP. Speech-language pathology job outlook. Expected to grow by 25% from 2019 to 2029. As a result of this growth, approximately 40,500 speech-language pathology jobs will be available over this 10-year period. A few reasons for growth include older populations, retirees. An expected increase in retirements throughout the coming years should create excellent job opportunities for speech-language pathologists. Increased survival rates. Medical advances are improving the survival rate of premature infants and trauma and stroke clients who then need assessment and possible treatment. And also early identification and diagnosis. Greater awareness of the importance of early identification and diagnosis of speech, language, and swallowing disorders in young children will increase employment for speech-language pathologists.
The impact of professional practice, so two kind of definitions here. So interprofessional education can be defined as when two or more health professions learn about, from, and with each other to foster effective collaboration and improve the outcomes and quality of care. Then the next one is interprofessional practice, which is defined as when two or more professionals effectively collaborate together to improve outcomes and the quality of care for their client. Both of those definitions came from the World Health Organization, and working collaboratively with other professions leads to positive client outcomes. So overall, the impact of working collaboratively with other professions can lead to enhanced patient care, which also leads to more positive patient outcomes. And PTs, OTs, and SLPs will all work together in order to help return the patient back to their prior level of function or close to that prior level of function. This is our last page of references, and then the next part of our video is just going to be a little snippet of our case study that we decided to base our video off of, and then following that case study description will be our video with a mock patient scenario. Alright, so this is our case study. I took this from the Phys Rehab book. They have some online resources for us as PT students to get a little extra practice with certain case studies, so that is where I got this one from. So a little bit of background. He's a 58-year-old male who has a right basal ganglia intraparenchymal hemorrhage. He currently is separated from his wife. However, they also maintain a supportive relationship. He also has 3 grown children who live locally. Living situation, he lives alone in a private house. He does have 5 steps to enter and 1 flight of stairs inside. And then his prior level of function, he was independent with all functional mobility and activities of daily living. And he is also working full-time as an engineer prior to this. So this next part is just going to be our mock patient, and then kind of different exam techniques that each profession might do with them. And then towards the end, we get together as a group to kind of talk about it, and then also kind of plan patient's goals and things like that.
Hi, Mr. Rogers. How are you today?
I'm good. How are you?
I'm good. I'm going to check your band here. Make sure. All right. Can you tell me your name?
Mr. Rogers,
Mr.
but I
Rogers?
think it's Jim.
Okay, Jim. Well, it's nice to meet you. I'm going to ask you a few more questions now. What is your date of birth?
6/25/19. The last 2 numbers is escaping me. for some
Okay.
reason.
And what about your address?
2473 42nd Street.
Okay, and what city is that? Is that here in Fargo?
I think we're here in Fargo.
Here in
yeah.
Fargo. Okay, Mr. Rogers, do you know why you are here today?
No, I just kind of woke up and I was here. I remember I woke up in the ER. Not real sure how I got here. Can't remember what happened
Okay.
before. Just kind of feel a little foggy, I guess.
Where were you and what were you doing before you ended up here?
Can't remember.
Can't remember.
Sorry.
Okay, so today we are going to do a few quick little tests, and then I will be out of here. Okay. The speech-language pathologist would conduct an assessment that includes a case history, a self-report, an oral mech exam, which is looking at oral structures at rest, a language assessment of other cognitive skills, and a feeding and swallowing assessment. So a couple common characteristics with right hemisphere dysfunction or right hemisphere damage is denial of illness, impulsivity, and the difficulty is usually more with language use. So to determine right hemisphere dysfunction, a speech-language pathologist may include different tasks such as a cancellation or a line drawing task, and also a reading and writing task to determine if there is left neglect. So for treatment, a speech-language pathologist may work on scanning techniques and also compensation and self-cueing to make sure to look at that right side if left neglect is present. A speech-language pathologist may also address the underlying problem, which may be attention. So typical goal areas for right hemisphere dysfunction include attention levels, pragmatics, which is the appropriate use of language, such as turn-taking and how close you are to a person. A speech-language pathologist should also determine how the neglect impacts reading and writing. So inattention to the stimuli on the left may include very large impacts on reading because of the neglect of words and letters to the left, and also these interruptions from left to right visual scanning, like how we typically read. It may impact writing also. The individual may have a tendency to shift writing to the right side and may leave out letters to the left. So as you can imagine, this would impact his career as an engineer, but also with everyday life. The speech-language pathologist should use a functional ability approach that focuses on functional skills important to daily communication and would involve the client in goal setting, and motivation is also necessary. The speech-language pathologist may also address swallowing safety due to the impulsivity. So the individual may impulse self-feed, and so we would want to give education and awareness of this, and then the impulsivity may also impact driving. The speech-language pathologist and occupational therapist may work together for cognition and cognition safety.
Occupational therapy would then come into the room and gather an occupational profile. The occupational profile includes gathering information about the client's occupational history and experiences, patterns of daily living, interests, values, and needs. This is information that is obtained through the client's perspectives through the form of an interview or a casual conversation. This assists in creating a client-centered and individualized approach to intervention. We would want to know his support system and what his social life and environment are supporting or hindering his performance in occupations. And we would also gather information on occupations that he previously enjoyed participating in to act as motivators within his recovery process. Following the occupational profile, we would complete a few assessments to assess his ADL and mobility. One assessment that we could use is the Barthel's Index. This is a scale used to measure performance in ADLs. It consists of 10 variables describing ADL and mobility, and these are scored. This can be administered through interview, observing the patient's performance in a specific setting, or by asking the patient to demonstrate an activity. We could also use the Section GG. Section GG is a standardized patient assessment to measure functional changes in self-care and mobility. This assesses the need for assistance with both self-care and mobility, and assesses through direct observation and reports from the patient, clinicians, care staff, and/or family. When possible, using a multidisciplinary approach is beneficial to the client. Occupational therapies will work to improve motor control and function of the left upper extremity and left lower extremity to maximize the patient's independence within self-care tasks and occupations within his life. Since the client is presenting with some cognitive deficits, we would find adaptations for following commands and short-term memory. He is also showing decreased endurance during activities, and since he requires frequent rest breaks throughout the therapy sessions, we would also work on increasing his endurance. We would also introduce one-handed dressing techniques to use to perform dressing independently as possible using adaptive equipment such as a shoehorn or a leg lift. He is also at a high risk of falls, so we would ensure to educate him on safety precautions, and due to his cognitive deficits, we could make visual reminders or other adaptations to work on these safety precautions. As an interprofessional approach, we could work on self-care or other occupational tasks while PT is working on balance or lower extremity control. We could also work with physical therapy on range of motion, positioning, muscle strength, and endurance, and we can work with speech and language pathology in addressing cognitive deficits. Hi, Mr. Rogers. I am your occupational therapist today.
Hi.
I've heard that you're having some troubles lifting your left arm.
Yeah, I
Okay.
can't do it at all.
Awesome. We're going to work on that a little bit, see how you're doing. So first I'm going to test your right arm because this one's not affected. You're feeling fine here?
Yeah.
Perfect. So can I have you lift this over your head like this? Awesome. Now can you do that on your own? Great job. So that one looks great. So we're going to test your left arm now. Okay, so we're going to go, you straighten it. Okay, I'm going to have you do that. Can you do it all by yourself?
That's about as far as I got.
About as far as you can go? Awesome. So during occupational therapy, we're going to try to stretch that out and increase that range of motion again.
My name's Isaac. I'm here with physical therapy. How are you, Mr. Rogers?
I'm good. How are you?
Lovely. It's a wonderful day, isn't it? I know it's probably not the best day for you, but I'm having a delightful day.
Yeah, I'm I'm glad you are because I'm not having a good day.
Oh, that's a shame. Well, anyways, what physical therapy does, have you ever had physical therapy before?
No, I haven't.
Okay, well, what we do is we specialize in functional movement and just kind of how the body works. And what we do, especially different from occupational therapy, is we focus on the lower body more than anything. So what we're going to do is try and see how you move around a bit and see if we can help you out with that and kind of see where you're at right now and how we can progress moving forward. Does that sound all right?
Yeah.
Okay, so we've done vitals. Everything looks wonderful. The nurses say you're in great shape. We can move you around. There's no real danger with moving around, okay? All right, so the first thing we're gonna do is see if we can get you sitting on the edge of the bed, all right? Okay, so your left side's impaired. At home, do you have a bed that's kind of up against the wall? Like, which way do you normally get out of bed?
I usually get out of my bed on my left side.
Okay, so what we're gonna try and do is roll over on your right side. Okay, so for starters, what we're gonna try and do is I'm going to help you. Are you able to get your leg over to the right side? Move your left leg over your right at all?
No.
Okay, well, I'm gonna help you with that. I just want you to try and mentally move everything. So what we're gonna also do is have you move towards or laying on your right arm, okay? So we're gonna rotate. And you can just slide over. This would be a bigger bed. Okay, and now what we're gonna do, I'm gonna hook onto your arm and we're gonna pull your legs over the edge. And I want you to push off with your right elbow. And I am here to assist you. Okay. Now, you want to lower the table for me? Right there. And I'd have you hold on to him, Mr. Rogers, 58-year-old, while I get a nice skate belt on you. Tap my nuts if you got it. This one, right? It's been a while. All right, so what we want to see from you here, are you able to maintain your stability without anybody holding on? Okay. You did wonderful. That's far better than I was expecting. Okay, so are you able to sit here and reach for anything? So, with your right hand, I want you to reach and try and touch my right hand. Can you try reaching out here?
My right hand?
Yep. Okay. There's your dynamic stability. Now what we're going to try and do, how tall did you say you are?
5'7".
Okay. This walker is the perfect height for you, maybe. And what we're going to try and do is stand up, okay? So what I want you to do is we're going to push off with your right hand and try and push off with both legs and push off with your left as much as you can, okay? Once again, we are here to assist you, and you'd probably do more because you're on the weak side here. So on 3, we're going to stand up, okay? 1, 2, 3. Excellent. So now we're just going to stand here and just try and keep your balance, okay? Excellent. Now, let's try and take a few steps. So in this scenario, because he can't use his leg, you'd be the one moving her left leg.
Okay.
if you want, it really doesn't matter. You can use an aid for this.
Okay.
For all that matters. All right, so we're going to take a step forward.
Probably my good leg first.
All right. So take a step forward with your right leg. And then we're going to move your left leg. Excellent. How do you feel?
A little dizzy.
Okay, would you like to sit down?
Yeah.
We got a nice wheelchair right next to you. So what I want you to do is reach back with your right arm until you feel, yeah, it's back. Until you feel the chair, and then we're going to slowly go down as slowly as you can. Your left arm.
As physical therapists, our role with this patient would be to stress safety and functional mobility. So our patient had a right-sided hemorrhagic stroke. His impairments would then be found on the left side of his body. He has left upper extremity and left lower extremity impairments. So in regards to those impairments, we need to make sure that he is able to functionally transfer to both sides since he does live alone. Or we need to take that into consideration if he's still having difficulty doing that when we're coming up with our discharge plan. So following our exam, it'll kind of just look like how he's doing with bed mobility. We're going to want to test for spasticity and increased tone. We're going to want to look at transfers and how that is going. And then our final big piece, especially with the lower extremity being involved, is to work on gait training and reteaching him how to walk and how to walk efficiently. And since currently he is a max assist of 2 when walking, so we're going to want to make sure that we work on walking with this patient. Some things to take into consideration are the cognitive things that speech and OT have previously found. So we're going to want to make sure we structure our commands by using the one-step commands, so he is able to increase his attention to what we're doing, and so that we are able to get the most benefit out of our treatment sessions. So as far as other outcome measures that we could potentially do with this patient, we could administer the FIM just to kind of get an idea of his functional independence with certain tasks, and also kind of helps us gauge about how much assistance he might need. We're going to continue to work on balance in standing and in sitting to help him get back to that functional reaching he might have to do at home and for other activities like that. As far as gait, he has difficulty advancing his left lower extremity, so with gait training we're going to work on providing some of that assistance in propelling that lower extremity forward, but then hopefully dialing it back to where he is doing it on his own. As far as things like sensation and strength, we're just going to kind of test for them as they come up. It being a stroke, you can kind of conclude that it's going to be impaired since he did have a hemorrhagic stroke. As far as goals, our current goal would be to get him to do 5 steps, as he has 5 steps to enter his house, and then he also does have a flight of stairs inside. But other than that, our main focus is going to be that functional training and safety, and just safety with transfers so that he is able to get to that next level of care.
Okay, did you guys go and see, or everyone seen Mr. Rogers? How do you think that went?
Yep. So I completed informal assessments with Mr. Rogers. After completing these assessments, I determined that he presents with right hemisphere dysfunction. It's also known as right hemisphere disorder or right hemisphere brain damage. So the informal assessments determined that his syntax, grammar, phonological processing, and word retrieval are not impacted. And he does appear to have some impacts on semantic processing of words and discourse processing, which includes narratives, prosody, and also pragmatics. So I will address attention levels, pragmatics, shopping or reading a grandchild a book. So I could work on scanning techniques with the book to bring awareness to his left side. I also wanted to inform both of you, along with other professionals, that it would be beneficial for you to use 1 or 2-step commands and nothing more complex than this, and also that you might want to take frequent breaks throughout your sessions.
Perfect, that sounds good. I kind of gathered a lot of that same information from my occupational profile. I gathered that he lives alone right now, so we definitely want to do a home eval before he gets into the process of being sent home. While he's in acute care, however, we're really going to focus on getting him back into doing those self-care techniques, such as we want to see how he's doing with toileting and bathing, and get him as independent as possible in those. For coach treat today, we kind of saw his balance and his mobility from a sit to stand, and I really want to work more on that, incorporating that into his self-care tasks, such as standing at the sink or standing, and increasing that endurance during those activities within his life.
All right, that sounds pretty close to what our visits were. As you know, me and OT co-treated for this. One of the main goals that we'd like to do is get up to 5 steps that he can do it, because that's what he has going into his home. But currently what we're at is lower extremity and upper extremity motor weakness and sensation loss with the left side. And that's kind of diminishing his bed mobility is a maximal assist single person. His transfer from supine to seated is a maximal assist one person, and seated to standing is a max 2-person assist. And we managed to walk 5 steps, but once again it was a maximal assist. We had one person moving his left lower extremity the entire time and holding him up, and he's doing well. He shows promise. He's very motivated to be here, and he's in a good mood, thankfully. And we're just going to try and work on what we did today and just try and improve that day to day as we go. His prognosis seems well, and hopefully that it can just keep going. As for goal setting, besides the 5 steps to get back into his house, the goals are just going to be related to his functionality and walking and getting more independent with that, his transfers and sitting and standing balance, bed mobility. All of his goals are just related to improving on his functional